I'm Fionnuala Breathnach. I'm a consultant obstetrician here at the Rotunda Hospital, and I have a special interest in gestational diabetes. So gestational diabetes requires a glucose tolerance test. And the rationale for that test is that for all pregnant women, we handle our sugars, circulating sugars, just a little bit differently. So during all pregnancies, our cells become a little bit lazy at responding to insulin. And insulin is the hormone that regulates how glucose gets taken up into cells and converted to energy. So we all need insulin, that hormone, to keep our sugar levels in a kind of a nice, normal, steady state. And during pregnancy, because our cells are not as responsive to insulin, sugar levels can drift up a little bit. And that is common to all pregnancies. And if that happens to a little bit of an exaggerated extent, then we call that gestational diabetes. And so the way we test for it is a test firstly of what the sugar levels are like in the fasting state. So after 12 hours of fasting, to see what your sugar levels are like, and then you get a sugary drink and a blood test an hour later, and then an hour after that again, just to see how your cells have responded to that intake of sugar. So important to realize that there are lots of risk factors for gestational diabetes, some of which there's a good chance we can't do a whole lot about. So we know that it is that exaggerated response to the pregnancy effect on insulin and glucose metabolism is often genetically driven. So we know that in some ethnicities and people from certain countries have really high rates of gestational diabetes, and others with a family history of diabetes will more often test positive for gestational diabetes, and sometimes carrying extra weight is a significant risk factor. But there's no doubt that there is a gene that is responsible for gestational diabetes also, and we see sometimes actually slim, fit, healthy women testing positive for gestational diabetes in a way that might surprise them, but typically those women will have a family history that has triggered the test. So for the things that you can modify, like for instance, the overweight risk factor, there's no doubt that reducing pre-pregnancy weight will reduce your risk of developing gestational diabetes. But important that women don't put themselves under undue pressure to, reduce or indeed eliminate the risk is likely not possible. So following a healthy lifestyle and adopting the lifestyle measures that are recommended for treatment of gestational diabetes is probably wise if somebody is considered to be at increased risk heading into pregnancy. Well, it's really critically important to make a distinction between gestational diabetes and type 1 or type 2 diabetes. So in fact, it's probably one of the most important concepts for somebody to get their heads around is the fact that this is not true diabetes. When we all consider the type of diabetes you might be familiar with, or you might be familiar with somebody having type 1 diabetes, they're typically young at the age of diagnosis and they're on insulin injections for life, and that condition carries with it a number of risks. It's critically important that those individuals with type 1 diabetes maintain their sugars within range. They can become very sick if they don't, and untreated type 1 diabetes is potentially life-threatening. But that is a completely different condition and is related to very low insulin levels or very low insulin production. So it's a completely different entity. And gestational diabetes needs to be recognised as something that with which you would really have nothing in common with somebody with type 1 diabetes. So increasingly gestational diabetes is being considered less of a condition and just more of a risk factor that is very manageable, that should be very manageable and treatable and modifiable, typically with not a whole lot of intervention, just a bit of monitoring, some lifestyle modification following a prescribed diet, with the effect that your sugar levels are effectively just the same as somebody who would test negative for gestational diabetes. And in those circumstances, the risk factor actually confers virtually no risk. Probably the most important thing to consider is the association with type 2 diabetes later in life. So women who test positive for gestational diabetes have an up to 50% prospect of developing type 2 diabetes later in life, in their 50s or 60s. And that is a significant diagnosis. Type 2 diabetes in an older population confers with it lots and lots of medical problems, and it is possible to modify that risk by maintaining those lifestyle interventions and that lifestyle modification that's recommended for gestational diabetes, sticking with those principles after pregnancy as an investment in reducing the risk of type 2 diabetes later in life is enormously beneficial. So that in fact gestational diabetes could be considered to be the gift of a lifetime and the opportunity of a lifetime to optimize general health a couple of decades further down the line. Type 2 diabetes typically isn't recognized until it's already done arterial damage or damage to the kidneys. And so once somebody has tested positive for gestational diabetes, the recommendation is that you would have a diabetes screen with your general practitioner once a year for the rest of your life. And that in itself is a very positive intervention and, like I said, sort of investment in long-term health. So once somebody tests positive for gestational diabetes, and really important for context reasons to recognize that this is super common. So currently we test all women with any risk factor at all, and in fact we treat people who have previously tested positive for gestational diabetes. And the result of that is that around 1 in 5 of our population is considered to have gestational diabetes here at the Rotunda, and that amounts to about 1,700 women a year. So testing positive for gestational diabetes puts you in very good company with a big portion of the population, okay? And it can be really disappointing for people, and sometimes women will feel that they've somehow, failed a test, or, they're being put on some punishing diet and can feel like they're being placed on the bold step. And it's really important not to consider it that way. The most important thing with gestational diabetes is really just recognize it and know that it's manageable, modifiable and fixable, like I said, to the point where your sugars are just the same as anybody else's. And for most people that will just take some dietary intervention. But ensuring that those dietary modifications are working requires that women would self-monitor, okay? So we provide women with a glucometer. It should arrive at your home, and we're in the process of linking up with an app that will assist you and empower you in monitoring your gestational diabetes. And so the testing is self-performed by the woman, is just assessing a finger prick blood glucose level in the fasting state, so just before breakfast in the morning, and then 1 hour after finishing each meal. So 1 hour after breakfast, lunch and dinner. Typically the screening time for gestational diabetes is around about 28 weeks into the pregnancy, because that's when that resistance to insulin kind of declares itself most commonly. And so it's at that time that we tend to do the screen, it's at that time that it's diagnosed, and then a woman would be looking at potentially another 10 or 11 weeks of this self-testing. But it is not the end of the world. We tell women to consider it just, a nuisance, but something that is certainly very doable, and people get used to it very, very quickly. And as soon as the baby is delivered, that's the end of it. So it is a short-term nuisance, and what we do is to have the midwives link in with that patient every 2 weeks or so, just to keep an eye on the sugars and to link them in with the dietitian to see what modifications might help to ensure that the sugars remain within range. And the kind of targets that we would have don't require for the sugar levels to be absolutely pristine and perfect for every time that they're monitored for the remaining 11 weeks of the pregnancy, but rather that most of them are below the threshold that might require more treatment. So for some women, if the sugar levels just can't adequately be controlled with the dietary measures, a minority of women will need additional treatment beyond diet, and that additional treatment is typically either metformin medication, a tablet that they take twice a day, which is safe for use in pregnancy, or insulin. Some women need to go straight onto insulin if their glucose tolerance test is very abnormal, and that's a very small number of women. And some women have a trial on the metformin and it's still not working, and then they need to add insulin also. But the vast majority of women will manage just with dietary modifications alone. Gestational diabetes, we know that kind of abnormal sugar metabolism leads to high insulin levels in the baby. So high circulating sugar levels in the mom, those sugars cross the placenta and will stimulate more insulin production in the baby. And insulin is a growth hormone. So probably what we concern ourselves most about is fetal growth and ensuring that a baby in the context of gestational diabetes isn't abnormally overgrown. Now obviously people have big babies all the time, and the most important determining factor for fetal size is actually genetic. But our job is to ensure that a baby who may appear to be on the big side isn't big as a consequence of abnormal sugar metabolism. It is for that reason that all women with gestational diabetes will have a formal kind of a growth assessment rather than a casual palpation, feeling the abdomen to get a sense clinically of what size the baby is. We try to get an ultrasound sense, a derived sense of what size the baby is at around about 32 weeks or so, knowing that later on gauging the baby's weight with ultrasound is actually very difficult and pretty inaccurate. So at about 32 weeks or so, we get a sense for fetal size, and that allows us to kind of project forward and make an estimate of what size the baby's expected to be close to the woman's due date. Most importantly, in the lead up to delivery, if a woman's sugar levels are very high and during the course of labour, therefore the baby's insulin levels are high, then just after delivery, a baby is born with high insulin levels, but obviously the sugar supply from mum has now gone. And that can result in a baby then having very low sugar levels in the newborn period. So having low sugar levels in the newborn period is what the neonatologists concern themselves most about, and that's why babies born to women with gestational diabetes will have routine sugar checks, typically 3 checks to make sure that they're normal within the first 24 hours after delivery. Delivering a big baby is something that women may have to contend with, or whether they've got gestational diabetes or not. And the judicious decision making around how and when the safest way is to deliver a baby is a kind of a common theme for all pregnancies. But gestational diabetes is taken into account if there is any kind of a perception that the baby might be big, and that might drive the recommended timing of delivery or how the baby gets delivered. We look at our figures for our gestational diabetes population every year, and we would be very heartened to see that actually complication rates in this population are really, really low. So things that you might read about, like for instance, a baby being, stuck in the birth canal, the shoulders being stuck. We haven't had, for instance, when we look at last year's figures, among 1,700 women, we had no cases of shoulder dystocia in this population, even though when you read about gestational diabetes, you read about that type of risk. And equally, you read about the risk of preeclampsia. The risk of preeclampsia in this population here is about 2%, which is very, very low. What I would say is that it is true of all complications of pregnancy, or all conditions that we pay attention to during pregnancy, that the associated complications are most commonly observed where that particular condition, whatever it is not recognised and not treated. So the complications you might read about are, for the most part, relate to untreated gestational diabetes. If you're test positive for gestational diabetes and you control your sugars, then your risk for fetal overgrowth or preeclampsia or difficult birth should be no different than the non-gestational diabetes woman. So the answer is yes, but I suppose important to realise that the definition of early in the context of pregnancy is under 37 weeks. So once 37 weeks is attained in a pregnancy, a baby born after 37 weeks is no longer considered preterm. It is, however, important to recognise that that is still maybe 3 weeks before a woman's due date. So for women with gestational diabetes who have uncomplicated gestational diabetes that is well controlled and have no other pregnancy complications, there's absolutely no reason why they can't wait for labour until an upper limit that we would recommend as being about 6 days over your due date, so 40 weeks plus 6 days. And the vast majority of people will have met their baby by 40 weeks and 6 days in any event. So in the event that gestational diabetes is less well controlled and requires medication, so for instance insulin, we usually recommend that delivery happens by around about 39 weeks or so, but that's very individualised and depends on the specific circumstance, whether there's something else going on, what type of delivery is planned, what the estimated size of the baby is, whether the woman has had a baby before. All of those factors are very individualised, but those would be, broadly speaking, what the ground rules might be for timing delivery. Yeah. So that's a really good question, in that we often ask ourselves, well, if somebody's had just tested positive for gestational diabetes on a first pregnancy, does it make sense then to conduct the next pregnancy in a kind of business as usual environment, and then waiting to do a test at 28 weeks? Because the recurrence prospect for gestational diabetes is actually very high. What is inherent in you, whatever risk factor is inherent in you that drives your tendency for gestational diabetes, is likely to be there all the time or for all of your pregnancies. And so it's for that reason that we recommend that women who've had gestational diabetes in a prior pregnancy take the approach of assuming that they've got the same kind of metabolism for all of their pregnancies. And so that doesn't mean that the kind of intensive monitoring that I described kicks in the minute you have a positive pregnancy test, but rather that once you've registered in the hospital for your next pregnancy, that we start with recommending the dietary principles from the first trimester, rather than trying to play catch up later on. So from the first trimester, that really means that the monitoring that I described would happen, but not every day, but rather on maybe 2 days of the week that the woman would self-monitor. And only in the event that that 2 day per week self-monitoring indicated that her sugar levels were high, might we recommend more frequent monitoring, and maybe then for some women starting medication early. For other women, there is a group of women whose risk profile will not be the same the next time around. So the first pregnancy might have been several years ago, and as an example, her risk profile may have changed in that that woman may have lost a lot of weight since her first pregnancy, and so her risk factors may not be the same. And that woman may, if she decides, actually, I don't want to do the self-monitoring for the first half of my pregnancy, she might decide instead to have a glucose tolerance test at 28 weeks or so, and that's a valid approach to take. It is important for us to realise that a small number of women who test positive for gestational diabetes actually have already got underlying type 2 diabetes that's just been kind of unmasked by pregnancy or first recognised in the pregnancy. And how do we identify that that's the case? Because it's not common, but it can happen. And we identify that that's the case because all women with gestational diabetes will have a follow-up test about 6 weeks after delivery when they're no longer pregnant, and the expectation should be that their sugars are normal because the environment that facilitated these elevated sugars is now gone, pregnancy is now out of their system, and they should screen negative for diabetes. So a positive test for diabetes, and again, that's the glucose tolerance test. If somebody tests positive 6 weeks after they've had a baby, then they have a diabetes issue that is unrelated to pregnancy, and that is type 2 diabetes. The very nature of gestational diabetes is that there are no symptoms. And again, I'd reiterate that this is not type 1 diabetes, and you wouldn't discuss it in the same breath as type 1 diabetes. And people will be familiar with individuals with type 1 diabetes having maybe presenting with excessive thirst and weight loss and being very sick and potentially being admitted to intensive care. None of those symptoms apply with gestational diabetes. So we don't ask patients about symptoms because the condition that I've described, slightly elevated sugar levels as a consequence of just altered metabolism that is inherent in pregnancy, that condition doesn't result in any symptoms. So it's unhelpful for somebody to decide, well, actually, I feel very well, or I don't feel excessively thirsty, or whatever, and to decide that that reassures them that they should not have gestational diabetes. And by the same token, somebody who is pregnant and is experiencing, what they perceive to be excessive thirst or tiredness, or, passing a lot of urine, that's not gestational diabetes.